Hello, Alish, can you hear me?
Yes, yes, I can hear you.
Okay, one second. I'll just share my slides and see if
Hmm.
it's because it's raining a little here. That's why. Can you
Yeah,
see?
so madam. Yes. Please do it on a screenshot of this thing. Yeah, perfect.
Okay, done.
Cool, cool, cool. Yeah. I'll
Oh,
send a
wait.
reminder to good evening, everyone. Today is the fourth series of our IAPS NextGen lecture series for case presentation. And for today's case, we have Dr. Evangeline Samuel. She's a final year resident of MCH at ICH Chennai. She'll be presenting a case on Hirschsprung disease. To evaluate her, we have got two eminent examiners of the country, Dr. Simiratan ma'am, she's HOD MAMC Delhi, and Dr. Vikesh Agarwal sir, who is not only the Secretary General of IAPS but also the HOD at Jabalpur Medical College. Without wasting due time, I would like to ask Evangeline to please start her case presentation. Over to you.
A very good evening, sir and ma'am. I hope I'm audible.
Yes.
Okay. My case for today is an 8 months old female child who's hailing from Kadalur in Tamil Nadu. She was brought by her mother and grandmother to our institute. Both of the informants were reliable. The child's chief complaint was that she's been passing stools via an
Yes, yes. There is some disturbance in the background. Please take care. Yeah.
The child's chief complaint is that she's passing stools via an opening that has been created surgically in the abdomen since day 4 of life. Elaborating on this history, the child has been passing stools via this opening, secondary to a surgery that was done on day 4 of life. She was actually brought on day 2 of life to our institute with complaints of not passing meconium spontaneously on the first day, associated with abdominal distension that started on the second day of life, which was gradually progressive and diffuse in nature, associated with vomiting that was non bilious and non projectile, which also started on day 2 of life. This child, after bringing to our institute, underwent a contrast study on day 3 and then was taken up for surgery where this opening was created on her abdomen through which she passed stool spontaneously with and hence her resolution of symptoms were noted. She was admitted for a total of 6 days during this period. Since that admission, the child has been thriving well and gaining weight. She has been passing stool spontaneously through the abdominal opening and has currently come for further management and definitive procedure for the same. The child has no history of distress or need for mechanical ventilation or prolonged ICU stay in the newborn period. Since after the newborn period, she's had no history of recurrent fever, loose stools, bloody stools, or foul smelling stools, or history of recurrent abdominal distension. She has no history of failure to thrive, or no history of bleeding or excessive protrusion via the surgical opening on the abdomen. Coming to relevant past history, other than the admission in the newborn period for evaluation and surgery, as I had expanded previously, the child has also undergone genetic testing and hearing assessment. There were no other admissions, and the child is a well thriving child till date. Coming to maternal and antenatal history, the mother has congenital deafness. She has no history of maternal hypothyroidism or diabetes. She had a non consanguineous marriage. This was her first pregnancy, which was an uncomplicated one. She was a booked and immunized mother with normal antenatal scans. The child was born via normal vaginal delivery at term with no labor complications. Coming to the neonatal history, the child was a term child who cried immediately after birth and did not need resuscitation. The birth weight was 2.6 kilograms, and as a child did not pass meconium within the first 24 hours, along with distension and non-bilious vomiting, the child was shifted to our hospital for further management. Post surgery, the mother had good child rearing practices as the child was given exclusive breastfeed till 6 months of age, after which weaning foods were started. Coming to family history, there is no family history of abdominal surgeries or limb anomalies. However, the mother is deaf and has differently colored eyes, as is shown in the picture here that I've provided. There is no history of sudden infant deaths in the family. The child was immunized appropriately for age and has achieved appropriate social and motor milestones for age, such as social smile, sitting with support, and grabbing objects. But however, her language and hearing milestones are delayed in the sense that the child does not turn to sounds or respond to loud stimuli. There is no startled responses noted by the mother. So coming to a summary of my history, my patient is a term male child who had abdominal distension, non-bilious vomiting, and non-spontaneous passage of meconium in the newborn period, who has undergone evaluation and creation of a surgical opening in the abdomen for the same, and has currently come for definitive management and is 8 months of age at this time. Her language milestones are delayed, and she has a family history of deafness and pigmentation defects.
Okay. So we will stop here for a brief. Ma'am, would you
Ah,
like to start, or
yes.
I put a few questions to her?
Let me start.
Yeah,
Now,
please.
you said that the child had delayed passage of meconium and also abdominal distension.
Yes,
So,
ma'am.
what are the causes of delayed passage of meconium and abdominal distension in a newborn?
So,
Because that will become your DDs.
yes, ma'am. So there can be a myriad of reasons which can be divided into medical and surgical. So medical reasons would be first a premature child with sepsis, with necrotizing enterocolitis, with electrolyte disturbance, and hypothyroidism, etc. While surgical causes can be, of course, a Hirschsprung disease, which would be classically seen as a non-passage of meconium spontaneously in the first day. Other causes can be atricias, meconium plug, or meconium ileus.
So, how you have ruled out once you said stoma, because we feel that you should be unbiased in that.
Yes,
So,
ma'am.
what do you think the stoma made for, and what, according to you, is the most closer diagnosis?
And
Uh,
also adding a similar question to Madam's question, you told that there is an opening, surgical opening created in the abdomen, but you
yes.
didn't describe where it is that and what is the possibility, what type of stoma it is, the consistency of the stool which is coming through the
Yes,
stoma,
that is very important.
so
That
that
is
you
Ye-
come
very.
to know that
Yes.
which type of stoma has been
Yes,
created.
sir. Yes, sir. Sir,
Hmm.
so the mother has given the history that the stoma was, I mean, the opening was created in the left lower part of the abdomen, and the stools that come out of it currently are quite solid in consistency. So this leads us to believe that it is a large bowel stoma, and and since it's in the left lower quadrant, we can assume that it is a sigmoid or a descending colostomy.
Okay.
So,
So, hmm.
okay.
So other DD, you said Hirschsprung or atresia, anything more?
Meconium ileus or meconium plug, ma'am.
Hmm. And anything more? Can
Surgery, yes.
hmm. Yeah, surgical only we are asking. Could it be a case of some rectal atresia?
Yes, ma'am. Rectal atricias, colonic atricias, yes, yes, ma'am.
Okay. So tell me that what in the history leads you to believe that it should be Hirschsprung or meconium ileus, whatever, out of these two. What in
So
the history?
the child has had one is that the non-spontaneous passage of meconium is common for all these conditions, ma'am. But
Hmm.
the mother also gives that history that for the first day when the child was not passing meconium, some in the outside hospital, some tube was inserted via the rectum, after which the child passed some amount, but again did not pass spontaneously. So that leads us to think that it could be a Hirschsprung disease. That's one
So,
point.
so now the next question arises, like in a Hirschsprung disease case, if you give a rectal wash or you do upper rectal examination, so how does the child respond? Some amount of feces, or what actually happens in
So there
Hirschsprung
will be a
disease?
purge of meconium and gas, which is seen on passing a dilator or an infant feeding tube beyond the part of the aganglionic segments. So this is classically seen in a short segment Hirschsprung disease. So mother is not very clear regarding that
Mhm.
history. It's a little difficult to get the history from her
Correct. So we
because
are
she
not
is
very
deaf
sure.
also.
We are not
So
very
yes,
sure that it was a case of Hirschsprung's disease.
yes,
But
yes.
as the stoma appears to be a sigmoid stoma, so goes in more in favor of this thing, Hirschsprung's disease.
Yes.
There are
And
few other.
there is one pointer in the history you said not. I heard it rightly.
Ma'am, sorry, ma'am, I couldn't get that.
Was it a non-bilious vomiting? You said, I think
No
I heard
bilious
it.
vomiting.
Yeah.
Yes, yes, ma'am.
So you should point to that also, because
Yes,
Yeah.
generally in atresia you will get
bilious
Bilious
vomiting. And in a complicated meconium ileus, there will be a distension at birth itself, not a progressive distension that starts on the day 2 of life.
So you should be very clear after the history, unfolding each and every cause, and then come to why you think it is a most important cause.
And when you give
Yes.
a rectal wash, how will you differentiate it is a case of Hirschsprung disease, as you told, the signs of Hirschsprung, but what will be the signs of meconium plug syndrome
So meconium plug
on
syndrome,
rectal wash?
when we give a rectal wash, the meconium that comes out will be in small
Mhm.
pellets with
No, no, no. It's a plug, no.
and it will be a very tenacious type of meconium.
Tenacious, tenacious, then long ribbon-like
Long
tenacious
ribbon.
plug comes out, which
Yes,
is in the terminal portion not stained with the bile. In the proximal portion, stained with the bile. I mean, it is meconium, which is sticky.
sticky.
It
Yes,
sticks. It sticks on the cloth or everything.
yes, sir.
Normal meconium also sticks, but that is more sticky. So pellets doesn't come out. Pellets come out through the ileum when we do surgical procedures.
Okay,
But
sir.
meconium plug is the sign of meconium plug syndrome.
Yes, sir.
Is there any relation between Hirschsprung disease and meconium plug syndrome? Got my
Can both the
question?
conditions
Ah,
coexist?
correct. See, it is like if any child is having meconium plug syndrome, you always suspect that that may be secondary to Hirschsprung disease, total colonic ganglionosis. Ganglionosis.
Yes, sir. Okay,
This is
sir.
the relation. So
Yes.
any child having meconium plug should undergo a rectal biopsy always as a rule.
Okay, sir. Yes, sir.
Two more points, ma'am, she mentioned, but I'm curious why she mentioned about that. One,
Hmm.
you mentioned about bloody, foul smelling stools. There is no history after creating stoma. So, is it a relevant point? After stoma, does stoma has like such type of symptoms? Enterocolitis, that is reflective of enterocolitis, right?
Yes, sir. Hirschsprung associated enterocolitis, I wanted to
So,
rule out.
can it happen in a patient who is having a stoma? When
It
does it happen?
it
Hirschsprung associated enterocolitis.
Hmm.
it usually happens in children who have not had a colostomy yet, but it is
Uh-huh.
still possible in children who have had a functional stoma, sir, because of the um, uh, mucosal or the innate barrier defects that are seen proximal even in the ganglionated bowel. Even though it is rarer, it can be
Yeah.
possible in
So
such.
more likely of diarrhea in a child with colostomy is infectious diarrhea, not enterocolitis in a child with colostomy. So one condition where bloody stools and foul-smelling stools happen is unoperated case of Hirschsprung, where sudden gush of liquid stools, foul-smelling, lot of air, blood. And second is post-operative.
Yes,
In
sir.
operated cases of Hirschsprung disease after Duhamel or whatsoever procedure you do, there are frequent episodes of enterocolitis. These are the two conditions where enterocolitis happen in Hirschsprung patients.
Yes, sir.
You never asked
So,
about antenatal ultrasound.
I've mentioned, sir. So the
Okay.
antenatal scans were normal for this mother.
So, is there any anorectal problem which you can diagnose preoperatively on antenatal ultrasound? Is there any sign or anything, any information you have about it?
In anorectal malformation, sir.
Yeah, anything. I mean, anorectal problem. I'm not talking about atrasias. I'm talking about colonic problems where you can identify it antenatally, or there may be some marker on antenatal ultrasound which can hint towards some anorectal malformation or complication.
Sir, they can be echogenic bowel loops, or they can even be markers of soft markers of aneuploidy as well, that can be seen in
No,
antenatal.
that is okay, aneuploidy, but echogenic bowel is an isolated soft marker. It is called a soft marker.
Soft
That
marker.
means it has not much clinical relevance. Echogenic bowel and polyhydramnios doesn't happen in colonic or anorectal malformation. So there is something called as microlithiasis, microfecoliths. Okay. So
Okay.
if you go through the literature, that is some very important sign which hints towards anorectal malformation.
Yes, sir.
Okay. Microliths in the feces. So if you find microliths inside the bowel, that hints towards anorectal malformation.
Yes, sir.
You highlighted a lot about differently colored eyes of the mother, deafness. What is the relevance of this point? without
So,
any conclusion. I mean, you did not conclude also in your history after. I mean,
uh,
telling the summary of the history. Yeah.
Other,
yes.
the child also suffers from
Uh,
this thing, heterochromia or not?
yes,
Only the
yes.
mother.
No, ma'am. The child also her language milestones and hearing milestones seem to be delayed according to the mother, and the child also has differently colored eyes, which exactly is the same as the mother does. So, which
Okay.
is why I wanted to take that history in order
So it
to.
is just like a coincidence, or like it is some clinical relevance.
So, since Hirschsprung disease is a neurocristopathy, sir, there are many
Mm,
syndromic
mm,
forms which can syndromes that are associated with Hirschsprung disease, which
mm.
can have symptoms such as these differently colored eyes and deafness. The most, I mean,
Microiridia, no?
heterochromia iridis, sir.
Heterochromia iridis, yeah.
So in the syndrome that most fits in with the history that the mother is giving would be a Waardenburg-Shaw syndrome.
Good. Fine. Ma'am, can we move forward with the examination? Yeah, please go ahead with the examination now.
Yes, sir. Coming to the examination, the child was examined in a warm, well-lit room in the mother's presence after adequate exposure. The child was active, alert, afebrile, and hydrated. There was no pallor, icterus, cyanosis, clubbing, dependent edema, or lymphadenopathy. The pulse rate was 92 per minute. The blood pressure was 92 by 54 millimeters of mercury, and the saturation was 99% on room air. The weight was 7.2 kg and the length of the child was 75 centimeters, both of which were between the 50th and 95th percentile for age. Coming to the head to toe examination, the child had syndromic facies. Coming from head to toe, the hair was normally pigmented. The eyes displayed heterochromia iridis. The child has a depressed nasal bridge along with low set ears. The child has dystopia canthorum with a smooth philtrum and no response to any auditory or loud stimuli that was given. The limbs were grossly normal. The spine was grossly normal. There was no cafe au lait spots seen on exposing her, and the skin pigmentation was uniform. Coming to abdominal examination, on inspection, the abdomen is flat. The umbilicus is normally inverted in the midline, halfway between the xiphisternum and the pubic symphysis. There were no visible loops or pulsations, no cry impulse seen in the inguinal hernial orifices. A colostomy was seen in the left iliac fossa, which appears to be a loop colostomy with the fecal output coming via the lateral opening, which was functioning well. The surrounding skin shows evidence of healed excoriations. The mucosa seems to be slightly hypertrophied with a mild cobblestone appearance. There is no stomal prolapse or any parastomal hernia. The anus on inspection is in normal in position and appearance. Coming to palpation, the abdomen was soft with no local rise in temperature, no tenderness or any peritonitic features were elicited. There were no palpable masses or organomegaly, and there was no cry impulse seen in the hernial orifices. Peristomal examination showed that the proximal and distal stomas allow a 19 to 20 size dilator freely, and per rectal examination showed that the anus was again confirmed to be normal in position and tone, which allowed the passage of the little finger, and there were no feculomas or masses that were palpable. Uh, the liver dullness began from the fifth intercostal space,
Okay.
right?
So anything further abnormal or everything in the abdominal examination was within?
Abdominal examination was normal,
Any
ma'am.
remarkable finding that you would like to tell? Otherwise, we take it that other system examination was normal.
In the neurological examination alone, the child was not responding to auditory stimuli, but there was no focal neurological deficits seen elsewhere, ma'am. That's all.
Okay. So with this background, coming to the syndrome. So you
Yes,
said the Waardenburg syndrome, you know that it has got some major criteria, minor
yes, ma'am.
criteria. So
Yes, ma'am.
tell what are the major criteria, what are minor, and
So
how the common.
Waardenburg syndrome has 5 major and 5 minor, ma'am. And a clinical diagnosis of Waardenburg syndrome requires either the presence of 2 major criteria or the presence of 1 major with 2 minor. So the major criteria are 5. One is the sensory neural deafness, the pybaldism or the white forelock, heterochromia iridis, an affected first degree relative, and the presence of uh, the uh, Yes, that's this thing, ma'am. And the minor criteria would be a dysplastic or a small ill-formed nasal ali, early pigmentation or early graying, uh, unibrow or cyanophrosis. Uh, uh,
But
yes, ma'am.
eye
Hmm.
position.
And dystopia canthorum would be a major criteria. Yes, ma'am.
Which is there in your patient.
Which is there. So she actually fulfills four of the five major criteria. So which is why we would like to consider her as a case of Wardenberg.
White forelock is not there.
Yes, sir.
Hmm.
Other than the white forelock,
Hmm.
she satisfies the remaining four major criteria.
How does it affect the, I mean, outcome of the patient? I mean, is there any relevance in outcome, not in management?
The outcome of syndromic patients generally tend to be a little worse as compared to non-syndromic forms of Hirschsprung disease, sir. They tend to have slightly increased rates of enterocolitis or bowel dysfunction post.
Hmm.
So they will
More
need
enterocolitis,
surgery.
more frequent enterocolitis, and sometimes intestinal neuronal dysplasia is more common in such children.
Yes, sir.
Which
Yeah.
all conditions increase the chances of enterocolitis in which all association besides the
Yes.
Wardenberg? Which other
For
association?
Waardenburg syndrome, ma'am.
Huh? Excuse me?
Uh, you're asking about Waardenburg syndrome, ma'am.
No, she
Ah,
is asking some other
um,
disease, some other syndrome, which increases the incidence of enterocolitis in Hirschsprung's disease.
Down syndrome children have
Down
a
syndrome.
yes,
greater tendency
very,
of HAC.
very good. And prematurity will also.
Prematurity, delayed diagnosis, and if they've had one previous episode of enterocolitis before the surgery, they tend to have a greater chance of enterocolitis post-op as well, ma'am. 60% increased rate.
And
Okay.
which type of operation has higher chances of enterocolitis post-operatively? As
Actually,
we are talking about it, that's why I asked this question.
there is no type of the type of pull through
Mhm.
surgery does not affect the chance of enterocolitis post-operatively, sir. It is only the time of diagnosis and the time of the surgery. That's all. But the type of pull through does not affect.
But still, one pull through is considered to be a slightly higher incidence.
Slightly higher, but not statistically significant, would be a
Mm.
SOAVE, ma'am.
Suave has got some other problem with it. It is more
Because
of
of
a
the tight cuff that may be left behind during a
that is sleeve abscess leads to that is more commonly seen in case of Suave
Yes, ma'am.
rather than enterocolitis.
Okay, ma'am.
In fact, it is said that Swenson can cause
Spencer.
because
Okay,
there
ma'am.
will be a narrower and in Duhamel pouchitis.
Oh,
So
yes,
that
ma'am.
Okay.
something very close to this anyway.
Yes, ma'am.
Okay.
So, so this is the, I mean, all the findings you have mentioned. Was some biopsy done? I mean, during the colostomy or after
Yes.
the colostomy?
At the
No?
time of colostomy, biopsy was done. Sir, can I display the old investigations that the child had?
So now after abdominal examination, you told one more last thing. NS you said is normal in position and appearance, and dilator is passed easily, and on putting finger, the tone is normal, and everything is normal, you said. But
Yes, sir.
how the anal examination or rectal examination is different in Hirschsprung disease as compared to normal children?
In the sense,
One
sir,
thing you already told that you remove the finger, lot of gush of fecal matter, air, and liquid stools comes out. That one you told already.
yes,
Some
sir.
other thing. You cannot like overlook the internal anal sphincter spasm
Spasm.
associated with Hirschsprung. Usually, when you put finger in such patients, the anus is very tight, rectum is narrow, not capacious. So
Not
normal
capacious.
rectum is capacious.
Yes, sir. Yes, sir.
Okay.
Yes,
It's a
sir.
very important point. You put your
This
finger
is
every,
really important that you should know that rectum almost collapses the
yeah.
finger.
In fact, it grips your finger. That is the right word. It grips your finger. And
Yes.
if you are able to pass your finger up to the dilated segment, then only you get gush and all that.
Yes, sir.
How it is different from like leave apart this colostomized patient. Suppose a 5, 6, 7 months old baby comes to you, or 1 year, 1.5 year baby comes to you. how it is different from habitual constipation?
Yes, sir. So, habitual constipation, the per rectal examination would be that there are feces that are seen till the verge, and there'll be a lax anal tone in cases of chronic constipation. While in children with Hirschsprung disease, the anal tone would be increased, and there will not be stools till the verge. It will be above the verge in these cases because of the
Above
increase.
the verge, you will find the stools in Hirschsprung disease?
Not impacted also. It will be more.
No, no. My
No,
leading
not
question
above the
is,
verge. Hmm.
do you find, I mean, your finger touching the stools in Hirschsprung
No,
disease?
no, no, sir. I mean to say like
Never.
above the level of the aganglionic segment. That's what
You
I mean.
can't, usually you cannot go above that segment. Na? It is a rectosigmoid. Your finger is not that long. It just touches the dilated segment and comes out.
Yes, sir.
So rarely
So
you
if
feel any stool touching your finger or fecolate touching your finger in Hirschsprung. Rather, you feel fecalomas inside the abdomen.
Yes, sir.
so going by that, supposing some physiological tests are done on this
Mm.
child, manometry is done, what all findings will be seen in patient with Hirschsprung disease?
The specialized manometry that is done for these suspected Hirschsprung disease children would be a RAIR or a rectoanal inhibitory reflex manometry, ma'am. So usually nowadays we have moved on to high resolution RAIR, in which there will be an instrument with around 20 channels along
No,
with.
no, I'm asking just the finding. I'm not
Oh,
asking you
just
the
just the
procedure.
Yeah.
finding.
See,
So
you answer
normally,
only that much which examiner is asking.
yes, sir.
Okay. So
You tell me two
like
findings.
two
Two
findings
findings
you
of
tell,
a
na?
Hirschsprung disease
One you said
on
absent
physiology.
RAIR. One you said absent RAIR. Correct.
Second,
Second one.
that forms the basis of your clinical examination.
The resting tone of the internal anal
Yes,
sphincter will be higher in a case of Hirschsprung disease.
yes.
And what is
Okay,
the third
that's
finding?
hmm.
Which will really make it complete. And that is intermittent rectal contractions.
Intermittent rectal contraction. Yes, sir.
Okay.
So can you tell me the neural pathway for RAIR?
Yes, ma'am. So,
What nerves are involved?
it is actually a local reflex, ma'am, among in the enteric nervous system itself. So, when the pressure in the rectum increases, it is sensed by mechanoreceptors, which then act on the inhibitory neurons inside the enteric nervous system, which then inhibit the resting tone of the internal anal sphincter, causing it to relax. So, it's a
Good.
local reflex that happens in the enteric nervous system itself.
Okay, that's good.
What inhibitory chemoreceptors or chemical neurotransmitter is responsible for relaxation of the internal sphincter? What exactly?
Nitric oxide, sir.
Very good. Nitric oxide. So that is the
Okay.
most accepted theory nowadays.
Yes,
So
sir.
one is we have one diagnostic tool, RAIR, that is manometry. What other diagnostic tools you have or what employed in this patient?
We can do biopsies, ma'am. So we have different types of biopsies
In
that we
in this patient, what was employed? They straight
in
away went for exploration because it was distended, or they undertook some other investigation also.
actually the child presented an emergency with the very distended abdomen. So they went ahead for a laparotomy, biopsies, and colostomy, ma'am. Can I display the
So can I ask you one question here?
yes, sir.
Suppose you were the surgeon and you get
Yes,
a child with distended abdomen with DD, as you said, Hirschsprung disease, atresia, meconium plug in your mind.
yes,
So
sir.
what incision you will adopt for exploratory laparotomy if you don't have a contrast enema with you which is showing a Hirschsprung disease, like in this patient?
I have not seen. Has she displayed the contrast enema?
No,
No,
they have not done it.
no, sir. They did it and then they went ahead in the emergency setting
Okay, so
itself.
that point is missing in your history. I mean, contrast enema before surgery was done, right?
Yes, sir. Yes, sir.
Can you show that contrast enema?
I've displayed it, sir. This was the admission X-ray, and then a contrast
What
was.
is there's some catch in this admission X-ray, which shows that it should be Hirschsprung.
Yes, ma'am. This is a plain radiograph which shows that there is a pelvic brim cutoff sign. That is
There.
that there is no air that is seen below the pelvic brim, which is suggestive of a Hirschsprung disease, along with globally dilated bowel loops, of course.
Okay,
Okay.
that's good.
So
Okay,
what are the various?
what percentage of cases you get this sign? Now tell this almost, yeah.
10 to 15% have this sign, ma'am.
Many more. It
Many more,
reaches to the
50% will
tune
have
of
this.
60% or so.
60%. Okay.
Ah.
So, what are the various signs of Hirschsprung disease you see on this neonatal contrast study I'm asking specifically,
Yes, sir. So,
which goes in favor of Hirschsprung's disease?
so we should see on injecting the contrast, we should see three distinct zones in the contrast study, sir. That is,
Show the contrast study film.
it's
It is there.
displayed on the right side now.
No, I'm not seeing it. Only the radiograph I'm seeing.
There are two images, madam. On right side, you can see lateral film of the contrast study.
Okay, found.
Yeah.
Fine.
Now describe it.
So there are three distinct zones that should be seen to make a diagnosis of Hirschsprung disease, sir. One is the distal contracted aganglionic zone, then a coning transition zone, and then a proximal dilated ganglionic. What we assume
So
to be.
I differ with you a little bit. You described the zones very correctly, but you should not call it ganglionated or non-ganglionated. You
Yes,
should
sir.
call
Yes.
narrow and
Narrow.
dilated segment.
Yes,
Okay?
sir. Yes, sir.
Transition is okay, but ganglionated is a histopathological term.
Histopathological. Yes, we assume. Yes, sir.
No, don't assume. You call
Yeah,
it
don't assume.
narrow, dilated, transition. One sign. Two,
Yes.
second
One.
sign.
Second should be the presence of a reversal of the recto-sigmoid ratio. So usually
Okay.
the rectum should be larger than the sigmoid because it's a capacious structure. So when we divide the ratio of the largest diameter of the rectum by the largest diameter of the sigmoid, normally this ratio should be more than 1. But in Hirschsprung disease, there is a reversal in which this ratio is less than 1.
Third sign. This
Third,
is fine.
third should be irregular contractions that are seen in that narrow contracted parts.
Not really. This is something you want to do fluoro for that or what? So
That is
why give
created
radiation and do fluoro?
It should
So
be seen under fluoro guidance, yes, so that
no,
irregular.
but why give so much radiation of fluoro for this study? What else? What are other important signs apart from this? Yeah, Tamojit, very good. So it's a neonatal, I specified it. So 24-hour film should be taken in all newborns. So if there is retention of contrast in 24-hour film, that is suggestive of Hirschsprung disease. Sometimes in neonates, you don't get this characteristic three segments. Narrow, transition, and dilated segment.
Yes, sir.
And
Sir,
what
can
are
I
the
just
other
ask a
conditions?
question, sir, at this?
What are the other conditions in which you don't get such
Ah,
clear cut signs?
One can be if there was a recent Hirschsprung associated enterocolitis. Second would be a long segment or a total colonic aganglionosis. A characteristic transition zone may not be obtained.
mhm. Then
Then
some other. You do a rectal examination in morning, in evening
And
you
then
check for
evening.
the contrast study. You will not
Yes.
get narrow
Recent
segment.
rectal wash has been given or some amount of
Correct. This is the
compression.
most common situation. Na? These two
Yes.
situations are most common. So that's
Yes.
how you prepare our patient. You stop the
Ye-
washes for 24 hours and then you do the contrast study.
Yes, sir. Sir,
what
What
the
about
other?
ultrashot? Will you get?
ma'am, actually, there now is a controversy about this ultra short Hirschsprung disease.
It
The
doesn't
latest,
matter. It is still, we do use this
Eh,
term.
अरे अब
Though,
तुम
we don't use the term ultra short anymore.
you don't
okay.
you don't use, but we use, na? We are old people. We still use it. You may not
Yeah.
use it because you read books only, na? But we treat patients, so we have to use it. Sometimes we cannot explain it with the short segment, long segment, anal fissure. Then we have to suspect the ultra short.
Yes,
So
sir.
there
In
is
ultra
little.
short, we may not get the transition zone on a contrast anymore.
So how do you diagnose ultra short segment Hirschsprung disease, which used to exist years back? Now it doesn't exist according to your evidence, but it does exist in the book chapter written by Dr. Kanishka Das also. Okay? Yeah,
Yeah.
tell me.
Sir, one is the RAIR will be absent in such cases,
Mhm.
and biopsy, which is taken beyond 1 centimeter but below 3 centimeters from the dentate line, that will show
Very good.
absence of ganglion cells.
So there is a definite way of taking biopsy in such patients. Okay?
Yes,
So
sir.
how do you take a biopsy in normal Hirschsprung disease? What are the various ways of taking biopsies?
There are two, basically there are two methods. So one is a rectal suction biopsy, and
Hmm.
one can be a partial thickness or a full thickness rectal biopsy.
What is the prerequisite of rectal suction biopsy?
The child, it is most useful in a child that is less than 3 months of age, sir. One. And second is that we should ensure that we have a good histopathologist who's able to identify.
Only only histopathologist or something else
And
with the histopathologist?
immunohistochemistry should also be available at our
Mhm.
center
For
in
what
order to
marker?
identify hypertrophic nerve fibers as well as acetylcholine esterase, which is
Correct.
actually seen in these
Why so? Why so?
there will be increased acetylcholine esterase that is seen in the submucosa
No,
of.
but that will be seen in full thickness also. So why you don't need histochemistry essentially, immunohistochemistry essentially in full thickness rectal biopsy, but you do need it for suction biopsy or mucosal biopsy. Why so?
Because the finding of hypertrophic nerve fibers may not be very prominent in these cases since we're
No.
only getting mucosa and
No.
submucosa.
Yeah, that is
Yeah,
the
yeah.
reason.
So mucosa only. No? That is
Mucosa.
important.
It is only some mucosa. You don't have myinteric plexus here.
We don't have the mindary plexus, so that is why
Yeah,
we need.
that should be your answer. Okay,
Mm.
correct. So, how do you process the sample for suction biopsy, for full thickness rectal biopsy, and for frozen section biopsy? In short, you tell.
Yes, sir. So our frozen biopsy should be sent in a saline soaked gauze, sir, for processing, in which they use it for acetylcholine esterase estimation in immunohistochemistry. Rectal suction and full thickness biopsies, usually we can in a full thickness we can split it into two and send, or in suction we have to take two different specimens. One will be sent in saline and one will be sent in that Roswell Park Memorial Institute
Very good.
medium.
And
It
full
should be
thickness
at
rectal
least,
biopsy,
yes, it should be at
any
least 3 mm
any
in
any
size.
specific thing which you will do before sending the specimen?
Yes, so we have to make sure that the specimen is mounted so that it does not curl up on itself and prevent
Very
proper
good. When
examination.
should you mount this sample?
Immediately after we remove the sample, it should be mounted and marked, which is proximal, distal, etc., which
Correct, marking.
etc.
Mhm.
Yes, immediately
And
after
then put in the formalin.
saline or whatever medium we are using. Yes, sir.
So normally, like we use that suture wrapper for that, all that. So
Yes, sir.
you can use anything. So this is very
Okay.
important step you should do: marking and mounting.
Yes, sir.
What are the stains that are available for biopsy, and what is the sensitivity specificity of rectal biopsy for Hirschsprung disease?
Ma'am, rectal biopsy is currently the gold standard for diagnosing Hirschsprung disease. So sensitivity approaches 100%, while specificity is around 95 to 98, depending on the.
No, it's opposite. You are saying sensitivity is around 93%,
Okay, ma'am.
specificity is 100%.
100%. Okay. Yes.
Someone wrote about donut biopsy in the group chat.
Hmm.
Can you tell me the importance of donut biopsy? Few people recommend it. I don't recommend it, but many people recommend it. What is donut biopsy?
So donut biopsy is when we take a full circumference of the bowel
Hmm.
for biopsy, sir, so that we can identify subcircumferential hypoganglionitis or aganglionosis. But that
When
is
do you do that?
that we do during the time of definitive procedure, either a primary pull through or a secondary procedure like a Duhamel or a Soave, etc. We cannot do that as a method of primary diagnosis.
Diagnosis.
Yes, sir.
Diagnosis. You can do at the time of leveling colostomy also.
Leveling colostomy also. Yes, sir.
Yeah, and definitive procedure also. So advantage is
Okay.
like there is variation in the presence of ganglion cells and nerve bundles at various levels. So you want to take a wider thing, but you need to have a histopathologist who can evaluate a donut biopsy.
Yes, sir.
Okay.
Okay.
Now you tell the
One,
various stains you have and what are the findings and
Yes.
what is the advantage and disadvantage of each.
Yes, ma'am. So
Hmm.
we can first stain for acetylcholine esterase activity, ma'am, which in Hirschsprung disease would be elevated because of the presence of the extrinsic preganglionic parasympathetic nerves, which are overactive in producing this acetylcholine. Then we have calretinin. Calretinin usually stains the ganglion cells. So when we are taking a diagnostic biopsy, it would be absent in such cases. Then we have S100, which stains the perineural tissue of the nerve.
What about HPE that we usually do and you are not mentioning it? The
Histopathology,
hematoxylin.
yes, ma'am.
Hemat-
Histopathology, we will see hypertrophic nerve
in
bundles.
your center, you do acetylcholine, this thing, ACHE first? Or
No, we do HNE first, and then if required,
so you
calretinin
should
as
mention what is more frequently
Ah,
done.
and 90% of the center or 99% don't do acetylcholinesterase. It is just mentioned in books. Very
yes,
few people practice that, and it is not easily available also.
yes,
And
sir.
very difficult to interpret. It is slightly challenging for
Mm.
and that we do in frozen only.
Yeah.
Yes, in histopathological HNE examination, we can see that there is an absence of ganglion cells with hypertrophic nerve fibers. The cutoff is 40 micrometers in diameter. This would be what would be seen in the aganglionic bowel.
So this micrometer cutoff you can measure with a normal compound microscope, or you need a special microscope for that.
We'll need an electron microscope for that.
Ah, so see, you say what you practice. Theoretical thing can be asked by the examiner, you can answer. There is no problem. Your knowledge is good. I appreciate that. But in practice, when you go like after MCH, you won't practice all these things. You won't get access to electron microscope so easily. It becomes expensive also. Now,
Yes.
organizers have prompted us that time is not much. So, ma'am, can we move towards management in short in this particular
Okay,
patient?
okay,
Yeah,
let's.
please. Please. Now you tell what will you do in this patient?
Sir, so now the child has come for a definitive procedure. In our center, we normally do the preoperative workup, make sure the child is fit for surgery, and then go ahead with a modified Duhamel retrorectal pull-through.
First thing, what will you do?
We have to
First
review
thing,
all the
ah,
um, records, biopsies,
most
contrast
important is
studies,
review the
etc.
biopsy. And if you have a clear cut biopsy of, like, surgeon may have taken the biopsy, may not have taken, may not have specified from where he has taken the biopsy. If there is any doubt, first do a biopsy.
Yes,
Confirm the ganglionosis. I mean,
yes.
presence of ganglion cells at the site of the stoma, from
Is
where
it
the stool is
possible
formed.
that the stoma has no ganglion cells still child is okay?
Uh,
Uh,
tell this.
If the stoma is functioning well, but the stomal biopsy shows that there are no ganglion cells, ma'am, maybe there was a mistake in the preservation of the biopsy or
No, it was okay only. It was okay.
or
Cross-check.
it is a transition level biopsy, transition zone colostomy. So hence it is functioning intermittently.
Okay. Okay, fine. So it was
Then
just a trap by madam.
no. Sometimes it is seen because there is a wave of peristalsis which pushes it. So even if there is a aganglionosis at the tip, there could still be
Hmm.
just probably the stoma was in a plus minus place that you said the transitional zone. Maybe it is a transitional zone stoma, and you may not get
So
the.
this patient's
Yeah.
biopsy is properly done. First, you have to identify it is properly done or not. If surgeon has not mentioned from where he has taken the biopsy exactly, it should be from the opening from where the stool is coming. See, it is very clear. If that documentation is not there, you will not trust that biopsy report. You repeat the biopsy because that is going to come down now.
Yes, sir.
Suppose it shows hypoganglionosis, then what will you do? But
Uh,
patient is passing stools normally, but
yes, sir.
histopathology is showing hypoganglionosis. Then what will you do?
So then, during the time of the definitive procedure, now would be the time where we can send an entire donut or a full circumference of the bowel that we are going to pull through, send it for a frozen section, and make sure that it is not a transition zone stoma. So once they confirm that circumferentially ganglion cells are present, then we can
Correct.
proceed with the rest of the
If
surgery.
you don't have a frozen section, then what will you do?
Then we can
You
do
have
a
frozen. You have frozen in
yes, yes.
IGCH. Okay.
Yes, sir,
I
we
don't
have.
have frozen. I don't have frozen. I do primary pull-throughs. So I have a solution for that. That's why I'm asking this question.
We can take a biopsy from the proximal stoma as well, sir, from the edge of the proximal stoma.
But that is hypoganglionosis. No, already. It will again show hypoganglionosis.
The
You need
patient
a
is
Or
out
if
biopsy.
we
for
are doing,
definitive repair.
or when we are
Ma'am.
doing the definitive repair, we can discard the last 3 centimeters of the pull-through bowel.
That is very arbitrary. You have to be very, very sure that what you are pulling down is ganglionated. Why not put a laparoscope and take a biopsy?
Oh, yes,
No,
sir. Yes, sir.
that's what we do. We don't have frozen. So in primary pull-throughs, we put a laparoscope, take seromuscular biopsies, send it first to pathology. After 5 days, we do the pull-through. Till then, we keep on washes.
Okay, sir.
So,
Yes, sir.
okay, you may go to some place where there may not be frozen facility. Then you have this solution. Still, it is evidence-based.
Yes, sir.
Okay.
Yes.
What operation you will, like you said, Duhamel, any particular reason why you want to do Duhamel? Which is the best operation according to you, Swenson, Duhamel, or Suaves? Suave nowadays we do is endoanal Suave or
Yes,
transanal
sir.
pull through. Okay.
Yes, sir.
Out of these three, which is the best operation according to you and why?
Sir, the post-operative outcome of all three procedures are similar or can be
Mhm.
comparable. It depends on the comfort of the surgeon as well as the facilities that are available in the hospital, which will decide the type of pull-through that we do. So,
Not really. Not really. Most popular operation.
Duhamel,
Why? Easy to learn,
easier
easy
to
to
do.
teach, easy to learn, easy to teach, easily adopted by anyone, and proprioceptive anterior rectum.
Yes, sir.
Okay, and many studies, yes, he is right, that many studies say that Duhamel has the best outcome. But now Swenson is emerging again with the advent of laparoscopy.
Yes, sir.
What is the advantage? One advantage of Swenson, although it is a technically demanding operation, and
Yes, sir.
nowadays it has faded out. I belong to generation where I have seen assisted operated Swensons also.
Yes, sir. The advantage, I mean, purposeful advantage of a Swenson would be that there would not be a pouch in these patients. So post-operative
Mhm.
constipation and fecal impaction in that pouch may be
Correct.
less in Swenson.
So we say it is the most anatomical operation. You remove the all disease segment completely in Swenson, which doesn't happen with Duhamel also and Suave also. Whole disease segment you remove only in one operation, and that is Swenson's.
Yes,
So
sir.
there is no residual disease.
Yes, sir.
It has supposedly, theoretically, most possibility of having maximum outcome. No residual segment.
Yes, sir.
But
It
disadvantage, technically demanding
will be demanding.
and
And we may disturb the internal anal sphincter while
mm,
doing the resection, sir.
not
And
really.
also,
Not really.
more importantly,
More importantly, what?
which surgeon is really afraid of?
Damage to nerves.
To the
Soradeep.
nerves.
Soradeep, very good. So
You
neuronal
everybody should
plexus.
know, no? Everybody should know the basic principle, main
Mm,
advantage, disadvantage of all the procedures, three type of procedure available.
yeah, correct. Ma'am, anything else? Because
No,
this
I
can
think
go.
time is
Uh,
also over.
yeah.
So I think we
So
can.
overall, Evangeline is of course is one of the most promising postgraduate of Indian Association of Pediatric Surgeons, and she has done extremely well. And at times we know, I mean, how to let you down. So at moments I let you down, but that was just like part of that process.
Mhm.
But you
And
did
first,
extremely well. Very good. Well done, ma'am. You want to say
yeah,
something?
same.
Hmm.
I share your viewpoints, and but a little bit of practical knowledge is also
Hmm.
important. Actually, when they know the case, na, then they don't think about much of the DDs. But I always tell my students that you have to approach the patient as if he is walking in your OPD. Then it
Ah,
is the best presentation of a case that you should
correct.
keep in mind.
And you have to manage it alone. You don't have a big system with you. You
Yes,
should
sir.
always know alternative options. Suppose ACHE is not available, frozen is not available, laparoscopy is not available. So you have to have solution for that. You cannot say in private practice that I don't have frozen, I cannot do your surgery.
Yes, sir.
Okay?
Yes, sir.
Thank you very much. on behalf of both the examiners for giving
Thank
us
you.
this opportunity. And well done, boys and girls. Please go ahead with continuing this particular informative session, which is very useful both for examiners because we interact with you, we know you, and for students also.
Thank you,
Thank
sir.
you.
Good
Thank you.
initiative. Good initiative, Vikesh.
Yeah,
Very
thank you.
nice. Yeah.
Thank you to both the teachers for this nice interactive and learnful session. I would request both the examiners to please submit the marks on the link shared with you. And with
Hmm.
Okay.
this, I would like to end the session, and the said recording will be available on the YouTube very soon. With this, I would like to sign off. Thank you so much. Good night.
Thank you very much.
Thank you, sir. Thank you, ma'am.